Happy to start.
Thank you. Thank you very much.
All right. So I'll welcome everybody to our two-weekly departmental seminar. And today we're having Klaus from Pressentin speaking. He's a family physician at UCT and an associate professor and head of the Division of Family Medicine. Before joining UCT in May 2020, Klaus worked mainly in rural areas of the public healthcare system in the Western Cape. He completed his PhD in 2017, which evaluated the impact of family physicians within the district healthcare system of South Africa. And his research focuses on health, human education. He's an NRFC rated researcher, and he's the co-conductor program in family medicine at UCT, and supervises a number of postgraduate research students in master's, doctoral, and also postdoctoral level. He's the editor-in-chief of the South African Family Practice Journal and serves on the Council of the College of Family Physicians of South Africa, and serving on the Education and Training Committee of the South African Academy of Family Physicians. He's committed to growing the scholarly foundation of the discipline of care partners, and partners with several regional and international collaborators in this respect. So Klaus is speaking today on the impact of takeaway. And before you start, we'll take questions afterwards. If you have a question, you can post it in the chat area. And if you want to receive CPD points, just please
Jeroen, we can't hear you very well. I don't know if it's I'm the only one. Jeroen, we can't hear you very well.
Okay, it doesn't matter because Klaus is going to be talking now. Sorry.
No, but you said something very important about CPD points.
CPD, yes.
To not delay any further, I'll post it in the chat. So there'll be a message in the chat about CPD points in a minute.
Thank you very much, colleagues. Thank you very much, Jeroen, for the warm introduction. And it's so nice to see colleagues from both locally, nationally, and afar joining us this afternoon. And welcome, or good morning and good afternoon, wherever you may be based. Yeah, so I'm really excited to be here, and in a way also learn from hopefully the group about the work that we've done, and which is an ongoing process. And maybe speaking also to a broader audience outside family medicine, which is always good from that disciplinary learning perspective. I'm sure there might be colleagues in other emerging disciplines or very established disciplines that may be also asking some of the same questions. And the hope is that we could maybe also bounce off ideas of look at different mechanisms or approaches about understanding our impact or influence. And I'll say a bit more about influence and impact later. But really, I want to showcase this work that we've been doing, and in a way it's slightly through a bit of a retrospective, reflective lens, looking at what we have done and whether some of the work we've done, especially the methods used, are still relevant today, and whether we might need to tweak or adjust or just completely redo those methods going forward. So to today's talk, I've got in essence two large areas of objectives. The first one is basically to describe our South African primary healthcare landscape, which might be quite familiar with many of the colleagues on the call. It might be that I'm missing something, so please also alert us to that. But in a way, it's describing the context in which the phenomenon of family medicine finds itself. And I'm talking largely from the public sector, but I think it's important right at the start also to note that we want to also view this question from a more comprehensive integrated health system perspective, especially as we are hopefully now again on our way to universal health coverage and national health insurance, and rethinking how can we best integrate different levels of care, but also the two sectors of care. So, and subsequently, I will then focus on the work we've done, and as mentioned, reflect on some of those methods, and then we could look at some future directions for research, education, advocacy, and but also collaboration. So I'm sure there might be opportunities from there. So coming to primary healthcare, how it's currently offered in the South African context, it is also good to note, as you know, that we have this two-tiered health system. We have inherited a number of interesting and challenging and sometimes complex, but often wicked problems, which our communities face, and in a way which the health and education systems aim to address, but we're realizing it's a whole of society approach to address the quadruple burden of disease, but also the unequal distribution of human resources. So especially from a both a national and then probably also a regional perspective. It was already said I mean, we've been having all these issues post 1994, but as you can know, in the pandemic era, and I wouldn't quite know if in the post-pandemic era, there are additional effects that have become quite a stark reality. That was the pandemic showed us, and it really highlighted all the gaps and the faults in the system. So the pandemic, as was written in this report, has highlighted these pre-existing weaknesses from a health service or health system perspective. And unless we prioritize interventions that are cost effective, South Africa will experience increasing mortality and morbidity from diseases that have been sidelined in favor of COVID. And that was written within the first few months of the pandemic. And unfortunately, some of that is still true. And as the authors have noted, that this outcome will obliterate all the hard-won improvements over the past decade, especially as we are committed to reaching our SDG 2030 targets. So talking about 2030, I mean, it's less than a decade from now. Children born this year will at that stage be early school going age, so just starting off primary school, and it's hard to imagine what is the landscape that they will inherit when they as they start their school career, and how many of these beautiful aspirations have been realized. 2030 is this dream, this target that is already viewed from different lenses internationally. As you know, the SDGs, especially the third one, is particularly relevant to health, but also nationally in terms of our national development plan, where there is definitely mention about the support and commitment towards primary healthcare and the role of family physicians in primary healthcare teams. At a local level in the Healthcare 2030 document, it is this philosophical move towards person-centeredness, and the shift from curative to a wellness approach, which really speaks to the comprehensive primary healthcare philosophy, which is I mean, central to family medicine, primary care, and a lot of our colleagues in adjacent disciplines. So, I mean, as we look on what is needed to how was the health system look to be able to provide comprehensive primary health care, one of the key components of this health system is the health workforce in achieving these goals. And in the South African Human Resources for Health, or HRH strategy, was exactly intended to do just that, to describe how the human resources need to look by 2030 in order to realize this beautiful dream of quality universal health coverage and a long and healthy life for all. Unfortunately, this was again also sidelined by the COVID pandemic, and we hope that this HRH strategy will there's opportunity and buy-in and political will to move this forward and really look at also investing in this strategy as part of the comprehensive strategy of building the health system. So the question is, where do family physicians fit into this strategy for HRH, especially for the primary healthcare system? And there are a few shots of colleagues that I had a pleasure of working with over the last 2 years. So we need to have a look then at the discipline of family medicine, because this is also the phenomenon of interest, and the topic of the talk is where is family medicine at as a discipline? And even though family medicine has been around for decades in many forms and shapes, as general practice within the school of public health and also community health, it was only formally recognized as a specialty discipline by the Health Professional Council, our national licensure body, in 2007. And this has then subsequently changed the training program to be in line with the other specialist disciplines into a 4-year residency or registrar program. And the first graduates from those new programs entered the district health system or the health system in 2011. It must be important to note that at the moment we have around just under 1,000 family physicians on the national register, and many of them have been grandfathered from the previous training models. A lot of our colleagues, senior colleagues, and thought leaders in the discipline have been patiently guiding this process. So many of us who are now at qualifying in the last decade are really grateful for the foundational work that has been done. And so the National Development Plan that I've referred to earlier, it does also recognize the role of family physicians that we have to play, especially at a clinical governance level, as a way of providing leadership as part of primary care teams, and working with the health system managers to improve the services. So at a national level, the leadership has published 2 national position papers on family medicine. The latest was earlier in this year, in March of 2022. And it's really aimed at guiding policymakers on how best to deploy this cadre of health workers. I mean, there is still, unfortunately, is quite a discrepant understanding of the role of family physicians. Family physicians have been deployed in various levels in the health system. There's also not quite the recognition in the private sector yet about the role of family physicians. So there's still a lot of work that needs to be done. And I need to get clarity. For instance, in certain provinces, family physicians are mainly placed at district hospitals, and not so much at primary care facilities, whereas in other provinces, family physicians were traditionally based at a higher level, level 2 or level 3, and that also is in a way reflected in the policy environment, where one can see how this confusion has caused an uncertainty about the role of the discipline. I mean, are we a subspecialty of general medicine, or where do we fit in, and what really is our role? So there's still a lot of work that needs to be done. 11 years after the first graduates have entered the health system. As you know, there's a pipeline of sorts, or pathway of training primary care doctors. And we really, I mean, this is now just zooming in on the doctor component of the primary care team, but we know that for comprehensive and high quality primary health care, we need a full primary healthcare team membership. We really appreciate that the primary care doctors are only a component of the team, and it might be that at different stages of the patient's health journey, that their needs may differ, and that different members of the healthcare team will play a strong leadership role in their care plan. But zooming in on the primary care doctor workforce, we have this in a way, quite a long way to train primary care doctors, which is quite inherited probably from the British, the Commonwealth approach to training doctors and healthcare professionals, maybe as opposed to other parts of the world, where we have a 6-year medical degree program, followed by 2 years of internship, and then another year of community service, only after which you can then decide, or the graduate can decide, where they want to practice, and where the need is. There's obviously a lot of push and pull factors about where graduates end up, and I think that's also another conversation about recruiting and training and the right types of health workers for our country's needs. But essentially, once you've completed your community service, graduates may then choose to go to the private sector, which is not at any degree saying that either sector is preferable, but if as a medical officer, one can then choose to do a diploma, which is another 2 years degrees, or you can do the 4-year MA degree, which will then where you will then end up as a family physician once you have completed your national exit exam through the colleges of medicine. The College of Family Physicians administers a national exit exam. Once registrars or registrants have completed the first 3 years of their MD program at one of the 9 universities nationally. So this is basically just a career path overview or outline, and realizing also that when we look at this from a research lens, that there's quite a heterogeneous group of primary care doctors that end up in the system, and you'll find out now also why it makes that a bit tricky and complicated from a applied research perspective. So just to also then to give more background to the roles and the scope of work that these family medicine specialists or expert generalists play. In the initial position paper, and still now there's this understanding that there are 6 main or key roles that family physicians play and are trained for throughout their quite intensive training program. But it can be grouped together in essentially 3 key areas where one could look at the clinical aspect, and that's especially around providing direct care or first contact care, either directly or indirectly as a consultant. So often family physicians are working as team leaders or consultants, seeing more complex patients with multimorbidity and supporting other members of the team. Then there are also trainers, and that could be capacitating the primary care team in the services, or more formal clinical training and supervision of students enrolled in undergraduate or postgraduate level. And then there's the leadership role, especially around clinical governance and community-oriented primary care services, where family physicians are then also trained to not only manage themselves, but also managing their teams in a very often challenging health service environment, and being in a way change agents and helping others to strengthen the service, to provide more person-centered care, and access to care where especially in the rural and underserved areas. So then just to have a look at the context again of the health service. As you can see, the yellow in the central are the 3 levels of hospital-based care, and then the purple aspect is the out of facility, more ambulatory care environment. And it's important then also to know that often the patient's journey is across the levels of care, and these transitions need to be managed quite carefully. And that's interesting here again, where we look at the phenomenon of interest, the role of family physicians in particular. That was the purpose of the study. So you will see this is the tertiary environment, central hospitals. typically where family physicians are not found, but it might be that they might be working in the OPD environment and providing leadership and service strengthening activities at that level. But then also they might also be working within level 2, but typically they are trained to perform their best roles within this level 1 district health service environment. That extends from the level 1 generalist hospital right through the patient's home. So this is a photo of 2 recent graduates of our discipline. And next, I'm going to change tack. Now that we've described the context where the phenomenon finds itself in, we're going to look more closely at the role of family medicine and family physicians within the context. As Jeroen has mentioned, I graduated with my PhD in 2017, and which was basically part of this national research project, which was led by Professor Bob Mash at Stellenbosch University. And one of the components of this national project was to study the influence or impact of family physicians within a South African setting. And it was quite ambitious in its very nature, because we also looked at several provinces. In the end, we looked at 7 of the 9 provinces. And this was just a background also to this research, the rationale for doing this research. Again, as mentioned before, this new discipline with these new graduates entered into the system, and this uncertainty at policy level about what do we do with this new animal in a way? Where do we employ them, and how best can they make a contribution? Yes, we have all these national training outcomes, but what evidence is being seen? And it was also then tricky to identify facilities that were in a way family medicine naive versus family physician containing. But we really hope that this research was timely and needed, and contributed to the both the local but also international conversation around creating research evidence and strengthening the rationale for training more family physicians, but also to look at the different types of tools or instruments to measure this influence of the phenomenon, realizing that the model of care and the way that family physicians are working locally differs quite substantially from how family medicine is practiced elsewhere in the world. So realizing that we needed local evidence, local instruments, and measurement tools. So we essentially had 2 conceptual frameworks to guide this research. The one was this modified causal chain by Vidas Donabedian, which essentially, as you can see, you can recognize in the center this causal chain from structure, processes, and outcomes that might ring familiar with many of you. But then we also introduced the elements of quality primary healthcare around the health system performance domains, especially around access, coordination, comprehensiveness, continuity, and efficiency. And then we viewed family physicians as a generic intervention plugged into this system that is meant to influence many of these areas, especially about genetic processes, but particularly around clinical processes, but then also hoping that we will have an influence and at strengthening the performance of the health system, bringing, enhancing access to more comprehensive, specialized services closer to the patient and community's homes. So this was the one framework. The other framework was the 6 roles of the family physician that I alluded to earlier. So when we looked at this research project, and when I say we, I'm really grateful to the partners of this national project, which included academic partners from a number of the other universities that train family physicians. We in a way sort of wanted to look at the health system as a patient. And if you were to see the family physicians as a drug or dose, we wanted to understand what is this influence of introducing this drug into the system or this patient of ours. And again, there was many levels to look at, but at the end we looked at 4 lenses, and the 4 lenses in particular are at the facility level, comparing facilities that were exposed to this drug to those that were not exposed. So in a way, seeing if that was possible. Another lens was then to zoom into the facility itself and do a 360-degree survey within the team to really gauge how the different team members experience the role of the family physician across the 6 roles, from the views of both managers, colleagues, and other members of the team that refer to the family physician, really looking at the comprehensive perspective and the different angles of influence. And then we zoomed out and looked at the district health system and compared the supply of family physicians to key indicators of health system or health service performance. We used the district health barometers dashboard that gave information about key areas of those clinical service areas. And then lastly, we interviewed district managers that had these, we thought they had this bird's eye view of their health system or health service that they govern and coordinate, and also to see from that lens, of that angle, but almost at 30,000 feet, what's happening in the system, and can they see any influences from a more qualitative lens. So as mentioned, we were in fact zooming in from a macro to a micro level to understand the circle of the family physician's influence. And this is another way of displaying the 4 study designs. But interestingly, we part of the process, we also looked at using existing and developing new instruments as part of this research project. So for the 360-degree tool, we used the tool that was the result of a master's project by Kevin Passio that we call the Family Physician Impact Assessment Tool, but it's essentially a 360-degree tool, as I've mentioned earlier, that asks the members of the team to rate the family physician across the 6 roles with a number of key statements in a survey questionnaire that was administered online. And then for the probably the most involved and tricky part of this, the 4 parts, was the cross-sectional comparison of the facilities with and without family physicians. We realized that we had to develop a different set of tools for district hospitals as opposed to community health centers or primary care facilities. And we almost combined a number of tools into like to provide a dashboard that we could compare the 2 facility types with. So then to provide then the results or the findings from this research, I will present it in these 4 levels, almost this onion peel level, from the family physicians' closest sphere of influence to their more remote, more disciplinary or more collective influence at the national level. So in terms of this model, at the team level, the results then showed that co-workers experienced the impact of family physicians high in especially 5 of the 6 roles. And it was interesting that only the capacity builder role was perceived as a moderate impact. But when we looked at also comparing with the facilities with and without family physicians, at the control facilities, we asked the members of the team to rate the senior or career medical officer, key medical officer at that facility across these same 6 roles, and then comparing that between the 2 facility types, it was clear that the family physician's impact was perceived to be greater from the perspective of the team members. And then at institutional facility level, so this was a study where we compared district hospitals and the community health centers. And it was essentially that it was interesting to note that at a district hospital level, the performance was perceived to be stronger in district hospitals with family physicians, especially around areas of clinical care, around especially child health. But at the community health centers, the scores were lower, especially for some of the domains in primary healthcare that we measured with the primary care assessment tool. And that was a concerning part that we found out. I mean, there's a lot of possible confounding variables, and one of the hypotheses were that to make sense of this finding was that family physicians were working especially at more larger facilities where there might be some different dynamics that we couldn't maybe have measured or accounted for at the control facilities. That is being followed up, and we actually wanting to relook at that finding and do further research around that. At district level, from the qualitative lens, the district managers agreed that family physicians had benefits or made a difference across these different domains of health system performance. And they valued that their contribution to strengthening clinical service across the quadruple disease burden, and they anticipated a positive impact as the numbers would grow within a district system. At a national level, looking at the comparison between a supply of family physicians per 10,000 population and district health barometers, in 2015 it was, I mean, as understandably, was that the supply was simply too low to really measure impact at that stage. We hope that subsequent research would show that benefit. So the highlights and the big picture summary then of these contributions at baseline at 2015-2016 showed that the family physicians did help to improve access to quality care. They provided a set of comprehensive clinical competencies closer to the community, especially in the rural and underserviced areas. They helped to strengthen the team. They help to improve the organization of care for their patients. And these findings were confirmed both at the macro level of the district manager and the local level of their co-workers. Yeah, so this has been quite a quick overview and a very I probably could have delved a lot deeper into a lot of the findings. I would welcome you to and I could share some more references of other work that summarize it in more detail. But I think a large part of this conversation, this presentation this afternoon, is to also ask us to reflect on the methods used. I mean, one of the questions was, are there newer frameworks that we could use? Does the Donabedian causal chain still hold water? Maybe there's some other things we can learn from the management sciences, public health sciences, or other methodologies that might help us to look at this. Also, maybe from an industrial psychology perspective, especially at the interpersonal level, those type of dynamics. We felt that the mixed methods approach was really useful. I mean, it was especially as the current suppliers at the time was quite low. I think we have seen a bit of a shift over the last 5 years since the last research. So it is an opportune time to be asking these questions about should we be looking at new and different methods, and also then to note that these instruments that we used were both a combination of adapted from different contexts and novel that were in a way piloted and implemented de novo for this research, which also begs the question, should we be looking at newer instruments to measure our impact? But realizing that this is for everyone involved in applied research in real world situations, that clearly there's the phenomenon itself, but also the system is highly complex, and the goalposts are shifting, Our roles and contributions are evolving and are quite differentiated across different contexts. So at the local level, there might be particular needs, and especially we as family physicians are trained to be just that. We are trained to be responsive to the needs of the local team and the local service. So which also complicates the researcher perspective. I mean, another part maybe to also reflect on is the whole thing about being a insider outsider. So in a way, being inside the discipline. For myself as a family physician, a graduate from the new training programs myself, it was quite an interesting journey, and I had to ask myself and my supervisor often these questions about what happens if the research doesn't show our value. Does it mean we close shop and stop training family physicians, or what are the implications? So I felt also this immense sense of duty towards discipline, but also challenging myself from a researcher's lens to know that the scientific method needs to be followed, and if the results that are not playing in your favor, you also need to be truthful and ethical about that, and to unpack what does it mean and how can one make sense about that. So at this stage and at this juncture, I'm going into the last few slides. I know I've got maybe only a few more minutes left, about future directions, especially from a research, education, and advocacy perspective. So as mentioned, there are emerging frameworks and instruments. This is a quite exciting one that was published earlier in 2022. That's also endorsed by the WHO, UNICEF, and WONCA, the World Family Doctor Association, together with the Primary Healthcare Performance Initiative. And this is a more elaborate dashboard, which also has a key part around human resources, which could really be a useful framework to look at, especially as with the renewed commitment to primary healthcare after the declaration of Astana. I mean, as we know, research impact, I mean, I was talking about influence and impact earlier, but also about the so what questions about, now that we are doing the research, how can we bring this back to the community we're serving? How can we make sure that the research feeds into the reviewing of our curricula, making sure that the teaching and the training of family physicians and family doctors at undergraduate level are appropriate. It might also be that there are other ways of documenting this impact, especially around storytelling. So say, yes, the data is important, the hard evidence needs to be there, but what about the other ways that our influence is documented? And this then also translates into this interplay between the education and health system. For the education system to be agile and responsive to the growing needs of the population, and the health system's response to the population needs, and then also making sure that the market and the training of health professionals is appropriate and relevant to the local context, so that we train fit for purpose graduates that when they graduate, that they are equipped and ready to meet the needs and the often evolving needs of the health system. So and then of course there's the need for advocacy for the discipline for social impact, and as a discipline at a national level and locally, there are many avenues and platforms where the advocacy is being shared. Also at a regional level, there is the Prima Famet and the WONCA, which is the World Organization of Family Doctors. At the African level, Prima Famet is really a network of academic family medicine departments across the African region. So these are all the platforms that I would encourage you to engage with, especially for established but also emerging members of our discipline and sister disciplines that we can talk to. And then to end off, I mean, just a few thoughts about I mean, what does all could mean is and especially as we think about what the results mean, where we are in June of 2022. if we, and I really have this pleasure of being part of the UCT environment the last 2 years, and witnessing how the game-changing moments and highlights in that, just the eyes that light up when students enter the primary care space, be it through formal teaching or through student-run Shawco clinics, and seeing how these opportunities really help shape the thinking and identity of the workforce, and these current and future colleagues. So I think it's essential that we, yes, we can't. Not everybody is going to be a family physician or a specialist necessarily, but priming people to and colleagues to be have that primary healthcare universal health coverage perspective, embracing those core principles and values, which in a way is also very much related to our Department of Family, Community and Emergency Care, but also to the broader faculty in terms of our social accountability mandate. There's work to be done also around career pathways, and mentorship and coaching and support and leadership development within the discipline. And there's some exciting initiatives within the National Academy, such as the Next 5 initiative. And then there's a need for growing the scholarly foundation of our discipline, to have more colleagues engaging with applied research. This research doesn't necessarily have to be linked with a formal degree, or it can be just being curious and asking the questions: how can I improve the care for my patients today, and how can I link up maybe with my academic department or my family physician at my facility to help contribute to some of the applied research work. I mean, this publication in the Annals of Family Medicine also earlier this year was very exciting. I mean, it's also maybe from a more US perspective, but I think speaks into the national, international agenda about the potential of primary care research, and also the need for wise investments, also from a funding perspective. And then, as I said earlier, about documenting the narratives and telling our stories, there's the short report series that was published during 2021, where there was also some experiences from the Western Cape documented as part of this series, which you can find online. I wish to acknowledge, I mean, all of these colleagues who were part of this PhD project, but also this ongoing relationship. Especially at the bottom right, you will see Professor Bob Mash, who's the head of family medicine at Stellenbosch University, and I'm thankful for the close relationship between our departments, and also at this stage we are reviewing the methods of the previous research study, and hope to also present it as a methods paper to which can be used to guide other colleagues and primary care researchers. There are a number of references, but I'm happy to make these slides available, and also share them in any way or format. You're welcome to reach out to me. My details are on the final slide. And yes, maybe as part of the Q&A, one could also ask, what are your thoughts on the design of future human resources for health research projects? Because I'm very sure that the same questions might be asked in other established or emerging disciplines that might want to ask what is their value, and how can they enhance their value to their communities that we are serving. Thank you very much, Jeroen and colleagues.
Thank you, Klaus, for the great talk. And obviously, being in a discipline myself, which has only recently been recognized as a specialist discipline, I was listening quite keenly to some of your story in terms of what's happened in the last 2 decades. I'm going to ask if anybody would like to ask questions, just to raise your hand, and then I'll open the question sessions. Maybe I can open with a quick question to you, and then we'll go on to Peter. From a global perspective, I mean, the family medicine is obviously still relatively new, not as new as sport and exercise medicine, but still. how do we compare to the global scene, and how do we differ primarily in the South African context?
Well, Jeroen, that's a great question. I know this is a question that colleagues have also been grappled with. I mean, within the World Organization of Family Doctors, there was this question about, is there a consensus, a global consensus about family medicine? The fact is, I mean, one of the key things is that family medicine is practiced in different models across the world. So there's for instance, maybe some of the more high income settings where family physicians are working much like we might could compare how our GP colleagues work in primary care in the private sector, where there's more of a one-on-one continuity of care, first contact care, compared to other settings such as South Africa, where the bulk of the primary care or first contact care, if you have a health problem, you go and see the clinic, where you are seen by a nursing professional or other healthcare worker, and not necessarily seen directly by a doctor. I think there are some core principles and values that are unique and shared across the globe. This commitment to person-centeredness, continuity, and whole person care, as well as family and community-centeredness. So there's some core values that are shared across different contexts that binds us together with our disciplinary colleagues in other settings. But I mean, I recently had the privilege of spending 2 weeks at the University of Minnesota, where I visited their family medicine department, which was established in 1969. So, so that was so to come to this family medicine department that had 8 or 9 residency programs across both metro and rural. Have have about 160 registrars in their program, with I mean faculty of I don't know, close to 100. I might be misquoting that, and to see what was done, what they have done over the last 50 odd years, was really inspirational. But then also realizing that they themselves, even though they're very established, and I think in the UK, the RCGP, the Royal College of GPs, is the biggest college in among all the colleges, but also grappling with the same existential, in a way, questions about what is our value add. So in a way, there are a lot of parallels and comparisons. But there's and I think there's a lot of them also saying, it was interesting in the States, especially they're looking at us for to see how can they learn from us to do community oriented care, and because they know COPC originates from South Africa, and they want to be more community engaged in the care, and maybe their health system or financing system is more fragmented than ours. So that was quite fascinating to hear that despite being more established, they also have different questions, and that there's opportunities to learn from each other.
Great. Hopefully we can lead. Peter, you had a question.
Hi, Klaus.
Hi, Peter.
Thanks for that. It was really interesting presentation, much more different from what I expected. And yeah, I just wanted to say two questions. Firstly, I was surprised when you said family medicine's only since 2007 or 2011. I thought that the former Medunza had been offering them way back in the 90s. So just understanding that. And secondly, I was just struck by how the question that you asked and the question you tried to answer is something I've been struggling with for emergency medicine, and the impact of emergency medicine and emergency medicine consultants in hospitals is something that I've wanted to tackle and never known quite how. So these are some tools that we could be using too, because I mean, personally, and I think a lot of colleagues I was looking who's on the call have come from the situation of USTA 20 years ago, which was just chaos and the most junior people running that hall of a casualty, to today. And you look around our emergency units around Cape Town and they are completely consultant driven, and it's a no-brainer for us the impact they've made, but no one's measured it. And I was sort of thinking of mortality and morbidity and comparing against a baseline we don't really have, but you've provided all these tools. So I think it's a low-hanging PhD for someone. Yeah, thank you.
Thank you, Peter.
Steve,
My question about Medunsa?
Yeah. Go ahead, Klaus.
Sorry, no, I don't know if Peter had a question, but I value
He
the
was
comment
asking about Medunsa and whether or not they had offered family medicine training
yes,
way back in
yes.
the 90s.
Oh, yes, about the yes. So I have to qualify that I mean, as I have mentioned also that there is the bulk of the family physicians, probably 2/3. I might be wrong, that are currently on the register are family physicians that have trained through previous training. So they, for quite some time, they were like different master's degrees and vocational programs, the MFAMmed and MPraxmed. And you're right, Medunsa and many of the other sites. I see Steve's hand is up, and other colleagues can probably share their experiences. Because as I understand, I mean, there's the academy has also written up the history of the South African Academy of Family Physicians that was actually already founded in 1980. So there's been a lot of groundwork that was done over the 27 years until it took the Health Professional Council to recognize this discipline as a new specialty. So I mean, at UCT, family medicine was formally started in the School of Public Health in 2001 with Professor Derek Hellenberg as the head, but already before that there were since the 90s there were several colleagues who are still with us who have been part of that emerging discipline. So both from a practice as well as an academic or teaching perspective, family medicine or family practice has been around for quite some time. I think it was more the establishment and reorganization of the training into the postgraduate MEd program and the residency program that led also to the agreed national standard outcomes, learning outcomes, so that all family physicians that are being trained at these 9 programs end up with the same standard nationally and the same national exit exam through the colleges of medicine. So yeah, that's the history in a nutshell. But I've got some resources that I can share with you about the full history of the discipline. It's also something that I'm very interested to document and help document.
Thanks, Klaus. Steve, you had a question.
Yeah, thanks, Klaus, for laying out the sort of longitudinal story, the history, which is always a powerful kind of narrative story in itself. Just a disclosure, I'm a Medunsa graduate from 1990. But what I wanted to say in response to your presentation is that the question I think you're asking at the end was about the framing of the story, and my framing was fundamentally altered or challenged by visiting Brazil, where the family physicians, such as they are very much part of a family health team. And when they call a conference of the teams. They don't call a conference of the family physicians. So this kind of exclusive, and some people have criticized it as being elitist, focus on the medical professional rather than the whole team, I think is a framing thing that might lead to different ways of thinking. So if we were able to measure teamwork more accurately, it's not necessarily the doctor who is the leader of the team. You find often, there's a facility manager or a medical manager or somebody else who's actually providing that leadership, and the doctor becomes he or she is a sort of more of a consultant than necessarily a leader. So the framing of it for me was quite different when I visited Brazil. It was and it was in the era, I must say, of a more socialist sort of government. So I'm happy that Lula is on the comeback. But anyway, I think it was. I think you were pointing at, is this the right frame? Could we look at it from a different perspective? Maybe your comments on that.
Absolutely. Thank you so much, Steve. Yes, I'm very glad that you mentioned the Brazilian family health example. Yeah, I mean, I also had the privilege of visiting Fortaleza with the World Unity for Health conference. And like you say, I was struck also by the philosophy of the team-based approach, and in a way, I'm hoping that's the same philosophy that we're trying to instill here about the MDT or the interdisciplinary care around the needs of the patient, knowing that at different stages of the patient's journey, different members of the team will need to be the champion or lead in the process, but again, always centered around the needs of the patient and their family. And I'm just thinking also that maybe that is exactly the reframing that we need also when we want to study our influence at the primary care facility level, especially in the space that's beyond the facility in the community space, which clearly is conceptually a different framework, or maybe extended framework that needs to be taken into consideration. But I think there's more thoughts needed around that. But I think that's an important aspect, and also appreciation that our roles as family physicians are in a way morphing, even though and I think it might, like you said, I mean, there is, I remember that initial responses also in the journal within the discipline about the concerns about whether this creation of family medicine as a specialist discipline was the right move, and whether we, I mean, to quote, we're seen as the saviors of a district hospital, and whether we have lost or given up some part of our identity as part of that recognition. So, and I think that sometimes, I think that's a conversation that's ongoing. Don't think we've quite sussed it out completely yet. But I think there's probably the way to look at it is to go back to our core disciplines, but also realizing that like I said, family medicine is not practiced in a vacuum. It's practiced through teams in a very changing landscape. It's also quite different across the different settings. I mean, even within the same city like Cape Town, it might be that the one substructure is family physicians are working a bit differently to their colleagues in the adjacent substructure, because the contextual needs might be different, and a team makeup is maybe different. But yeah, that's a good point, Steve. Thank you.
Thank you, Klaus. And Murray had the next question. Go ahead.
Thank you. I cannot agree more with Steve. I was thinking about the same, in a similar way, the onion diagram that you had about the levels of care from tertiary down to the home of the patient, and how the family physician can be the coordinator of that care. However, there are huge amounts of patients who need coordination, who just can't navigate that system in its complexities and making sure that they're at the right place for the right care. And many clinicians don't do proper coordination and continuity of care, but the family physician can then be the catalyst to bring that about. However, we are few, so we need teams to do that, and that's where we are currently looking at rethinking a bit on the training of clinical associates, whether the clinical associate can't be that case manager or coordinator of care, and the family physician would be the facilitator, the leader of the team, or the catalyst of triggering proper and good coordination of care in a person-centered manner in our health system between all the different levels of care from tertiary down to the home of the patient. And that we can actually multiply our effect through having the clinical associates in our domain, in our teams, doing exactly that and training them for exactly that. So there's no profession that officially gets trained into coordination of care. You get trained in clinical medicine, but to be trained in coordination of care would be an aspect that would make the team of family physician with clinical associates quite impactful. Some thoughts that we're thinking about on this side from Pretoria. Thank you.
Thank you very much, Murray, and thank you very much for joining. Yeah, I think that's beautifully said. But how do we train our graduates to help their team members, capacity team members, but also how to help our patients navigate this system? I mean, yes, we want to fix the system and make it more streamlined and less murky, and but in reality, yeah, I think that maybe that's something Ishak will also speak to from a health promotion perspective. But definitely our influence is felt indirectly often, and at least that's what we aspire to.
Well, talking about Ishak, he had the next question for you, Klaus. So Ishak,
I saw his hand. Yes. Thanks, June.
Thanks, Klaus. Excellent presentation and fantastic piece of work, Klaus. I mean, I must say, like for me, kind of having literally grown up in post graduation in the Cape Flats, kind of, and seeing the metamorphosis of community health centers under the leadership of family physicians. I think that family physicians are playing an incredible role as change agents in the system, and I think that it's a matter of giving them that greater kind of feeling of empowerment and capacity to say that this is your mandate, run with it, kind of thing. That agency, I think, it's about strengthening that. I mean, already I can see there's a lot that has happened from that perspective. I mean, just if I can relate to you my own story of when I was an intern or rather a community service doctor at a CHC years ago, really struggling to kind of see the implement the principles we were taught as undergraduate students, but now kind of going back into the spaces and seeing what people are doing, being amazed by that. And I think that other spaces, coming from having trained subsequently in internal medicine, I see family medicine as really playing a leading role in giving us understanding on things like leadership and management and giving kind of the rest of the health science disciplines leadership on that. So I mean, you comment that family medicine being a subspecialty of internal medicine, I'd say it's the other way around. As far as that's concerned, each of these kind of internal medicine, pediatrics, we actually get to the patient comes undifferentiated from you to these different specialities as such.
Thank you so much, Ishak. Really appreciate that coming from a physician and an honorary family physician. No, but I think your remark about leadership and training leadership. I mean, it's something that's I'm very fortunate to help convene that leadership and governance module in our third year postgraduate program, and it's really a passion also for me to see how can we capacitate our colleagues in their own managing themselves, but also managing those around them from a leadership perspective. But that change agency that you refer to, and that's maybe a cross-cutting activity that we can do across disciplines, also within the department, but in the faculty. And I know there's a lot of work being done looking at how do we train leadership and governance. So it might be a cross-cutting activity that we could explore.
Thanks, Klaus.
Thanks, Klaus.
Richard, you had a question.
Thanks very much. Klaus, thank you very much for your presentation. Just reflecting on the way forward, and you wondering about future research methodologies, questions, participants. Steve has already mentioned the interpersonal being, or the interprofessional stroke, particularly being so critical in terms of the teamwork concept and the collaboration and the communication, etc., within the team, being important for us to be looking to measure from a team perspective. I note that the four themes of or the four lenses through which this research was approached, the interpersonal, facility, district, and national. The reality is that I have a sense, and you can refute me, that the impact at particularly at an interpersonal level and potentially a facility level are quite difficult to measure in an objective fashion. Or perhaps one of those themes, let me not put words in your mouth, would be more difficult to measure than others. But also the realities of South Africa, that the family physicians, or the inputs and the places of work and the contributions of family physicians in South Africa are very different one province to another. And and it is often more at a district level or sub-district level that family physicians are posted or responsible for, rather than facility or within individual teams. And did that realities impact on the research in any way, and how might that change your thinking going forward in terms of tweaking the research? And secondly, you commented on the what I might frame as my words, not yours, sort of researching ourselves as family physicians, and that speaks to the broader partnership between service and academia, in a sense. In that if can you comment on the intersection, but perhaps between the quality assurance on the one side, with that I'm going to include participatory action research, versus on the other side more formal research that's perhaps non-participatory in that context, and whether we could look to tests of change that we're documenting and innovations in the former space, rather than the place for retrospective formal research projects in the latter. Is there just some ideas around how we might move in the future, or your comment on that? Thank you.
Oh, thank you, Richard, and thank you for joining. I don't know if colleagues know, but Richard is the head of family medicine at WITS, and WITS was also, I think, a number of the colleagues on the call actually were part of the national research project. So I really appreciate those two questions, which are so I like the question about so the different levels, and yeah, I mean, I suppose when one looks more closely at the level of the individual or team level, it becomes more granular in aspect, but that is probably more heterogeneous, and it would probably be quite tricky to, especially from a quantitative lens or positive view, to distinguish the signal from the noise, to see what is the influence of the family physician, and vice versa also. So I think, especially if you zoom out, then there might be even more confounding factors that also come into play. So that's in a way was the beauty of having the opportunity to do the research at the time, 2015, 2016, when the new graduates were emerging. There was a shift in policy in terms of creating posts at the district and sub-district level, whereas previously the posts were often quite at level 2 or higher up in the system. So that provided a beautiful opportunity in a way in terms of the timing of the project. And the question is whether one will be able to replicate it in its exact nature, especially as the context has changed. I mean, on the one hand, it would be nice to, if you want to compare apples with apples, to use the same methods to see if there was shifts. But I think there's a lot of things that have been happening, especially from that framework, other genetic interventions and structural interventions that and changes that has happened. But I think that links it with your next question so beautifully, is that when we to maybe also look at maybe that's something to do, is to have a national research agenda of primary care, is to look at the different methodologies and having the qualitative, quantitative, but also the participatory view, especially from a more prospective quality improvement perspective. And I think that's what we've been, in a way, talking about also at the national level through the Education and Training Committee of the Academy, where we're looking at enhancing the research, but also the supervisory capacity for both master's and doctoral level, so that we can come up with projects that are maybe more robust and more multi-center, and also to partner with other researchers and expertise in other disciplines that could bring in the lenses that we want, the qualitative, especially the psychosocial aspects of our work. So good questions, Richard. I unfortunately don't have the particular answers, but I think that your remarks were certainly quite guiding in our reflections about the methods used from the baseline study. But I think there's more work to be done and more conversations to be had as we plan the next projects.
Thanks, Klaus, and thanks for hanging in there. We're well over the hour, but we've still got 2 questions, if you don't mind. So the first one is from Virginia, and then we're going to end off with Carl. So Virginia, please go ahead.
Thanks for a fabulous presentation. I had no idea you'd done this for your PhD. I did something on my own specialty for my PhD, which is on public health medicine, to look at its impact. So it would be actually great to actually look at your PhD and see if there are differences and how we could perhaps learn from each other. I really had 2 comments. Firstly, you tried to compare the impacts of family medicine by comparing facilities with and without. I think that is a far too crude way of trying to do something. It's too many unmeasured confounders and variables. I mean, for example, if we think about how we put in for the NHI pilots, and try to see if they may have had any impact. And of course, they didn't have any impact because the pilots were done in the poorest functioning facilities, and there might be reasons why that you found, like, for example, that the family physicians were being put into like the hectic facilities that were poorly managed in the past, etc. Just about methods, I see that some of the colleagues from emergency medicine are on the call, and they have used a technique with SenseMaker, where you can actually use quantitative and qualitative methods to come up with a theory of what makes a difference. Because I know from my own experience that family medicine specialists do make a difference, and the experience really is even with my official hat, when I look after research for the province, when we have a family physician in a facility and people want access to that facility, they can make it happen. They create an enabling environment for a whole lot of initiatives to take place. They're not measured because those aren't the things we often measure, but certainly they do make a difference. And I think one of the things that they do is create enabling environments in facilities for initiatives, for people to take risks, to try things out. And I do think that one of the skill sets that perhaps your specialty should look into in the training of family physicians in the future are quality improvement skills, because that is, you're faced at the coalface with those systems, and people can make a difference by by quick and easy methods. And I don't think it's part of your training. It's a bit of an overlap area with public health medicine as well, because we also look at that, and it's the Donabedian stuff as well. And so I wanted to end off with a question is, you've been part of your discipline's been part of the School of Public Health and Family Medicine in our school for since the school was started. I want to know what you think the overlap and the differences are between family medicine and public health, because I think we've got a lot in common and we don't want competition between the specialties. Thanks.
Wow, Virginia, thank you so much for these wonderful remarks. I do agree that we must have a coffee date soon. I think that, I mean, just the last question, I mean, it reminds me every time when someone asks me that exact question is, I reminded about David Saunders, the late David Saunders, who talked about the schism between person-centered care and community-centered care. And the need to bridge that. I remember him talking at the Towards Unified Health conference in Johannesburg in 2015, and that really is still standing with me. And I don't think our disciplines are in competition. I think there's in fact quite a bit of overlap. Like you say, I mean, I'm just thinking about my experience the last 2 years in the School of Public Health, and we are now in a process of migrating into a new department, but this is, like you say, not farewells. I think it's more of opportunity of the young discipline growing up and still remaining in touch with the mothership, so to speak. And I think it would be interesting also to look at, from academic perspective and a curriculum perspective, how what this means also for the emerging and maturing relationships between our disciplines. Because you're right. I mean, we are maybe maybe family medicine may be seen as more of the clinical primary care specialty, but definitely looking at their community through the lens of the patient and community in front of them, whereas public health complements the view from the more maybe the systems or service perspective. And I know there was also recent debate about service versus system, and I think both of our disciplines are in a way worried about the things that happen outside the health system, the things that affect the health of our patients and communities, and all the social determinants and the political determinants of health. So I think we've got so many interface areas. So I'm really excited that you've mentioned your project as well, and I would be, from a methods perspective, I think there's a lot to learn, but also I think from the teaching perspective, which we can see, because like you say about leadership and clinical governance, I mean, interestingly, probably half of the faculty in our leadership and governance module, or maybe almost half, are public health specialists. So talking about system strengthening, quality improvement, those things is something we're working quite closely together. So I think it's probably just and I think I see the comment also from Shemaine in the chat about the sense maker potential, and I think maybe having that mixed methods approach, realizing that you can't really control for all the confounders in the messy reality of the health services, and maybe also, like you say, looking at the low hanging fruit of a lot of our colleagues doing amazing work, just like you say, creating an enabling environment and the organizational culture for change. So I think there's certainly a lot that's happening, that's already happening, like you say, and I think it's more about capturing those stories, especially from an advocacy and policy changing environment. Thank you so much, Virginia.
Klaus, thanks for hanging in there. We've got one more question from Carl, and then we're going to wrap things up. So your stamina is there to see.
I'm learning a lot, and I'm being invigorated by the conversation.
Good. Go for
Thank
it,
you, Klaus, for the presentation, and I'm hoping to keep it short because we've been for a while. But yeah, I just wanted to get a sense. I mean, I know you've looked at these facilities with or without family physicians. I was wondering whether you saw any difference between rural and urban facilities, whether there was any difference between them, and then also just I'm not sure if this was kind of part of the scope, but I think when you kind of list all the roles of the family physician, I mean, it's kind of all things to all people, and this, I don't know if you ever had a sense of that there's maybe a little bit too much on the plate of the family physician. There can be too much expected of them, and whether that is reflected in the experiences and talking to family physicians in that way. And so those are my first two questions. My last one is just the interesting fact that there seems to be an impact on the community health centers versus, sorry, in the district hospitals, they were seen as impactful, but not so much the community health centers. And I mean, just reflecting from my experience, just as a physician, a rural doctor in our setting, I mean, it's interesting how I think that when I go to, a community health center or clinic, there's lots of things that I can do there and patients that I can see, but I sometimes feel like my skills are not as useful in the kind of day-to-day churning through patients than they would be in the family in a district hospital, where there's quite a lot more happening, and where a senior person with skills can support the junior doctors, go in and help out with the cesarean section, relocate a shoulder. There's just a little bit more going on, and so in a way, that experience and the broader experience of a family physician might be more useful. Not that I'm not a family physician. I've just been in rural medicine and worked as one for a long time. But I think that might be one of the things underlying it. I'd be interested to see what you think about that. Thank you.
Thank you so much, Carl, and thank you very much for bringing in the rural voice. I think, it's such great questions. I mean, it's interesting. Just your first question was about the comparison of the facilities, and we did look at that from both the facility perspective, but also the 360-degree survey. And it was interesting to note that the rurality, or comparing rural and urban facilities, didn't affect the results. So the same benefits of having family physicians were evident also in the rural facilities. So that didn't play a role, because that was one of the key things, especially when we looked at, we had a whole list of facilities that had family physicians, so just in terms of the process of identifying facilities, and then we purposefully or we randomly selected those facilities for each of the 7 provinces, and making sure that there's a rural urban representation, and then there were matching criteria to make sure that the comparison facility was appropriately matched. I think for district hospitals, it was something like bed size. There were some key matching criteria, and then for CHCs, we looked at the head counts to make sure there's at least, and also the urban and rural were represented. So that was interesting to note that didn't show any difference, that there was the influence of family physicians was seen as more pronounced in a rural or urban setting. And it was, in fact, a good thing, as we know that we realized that the results confirmed the value in both settings. As to the 6 roles, I remember, I think it was Dr. Joe Cupido who mentioned that this, when he was quite instrumental in establishing family medicine posts in the Western Cape. His words were something to the effect of this Hercules that we created, or aimed to create, about having this specialist with all these many arms and hats that has to play all these roles. And I think our research with interviews with the district managers reflected the same, and it highlighted the need for role maturation and role transition as you graduate as a newly qualified family physician. That initially maybe your focus would be more on the clinical consultant role, and gradually as you mature in that role, also maturing as a health professional and person, that you might take on the more senior roles as well. But I mean, seniority is not really the thing, because we know that there are excellent teachers and excellent leaders at a junior career level. So that isn't a factor in itself, but I think there's maybe just the appreciation that this transition from being a registrar to a junior consultant is quite a shift, and it would need some mentoring and support. And I think that's where the Academy, with its Next 5 initiative, wants to support these newly qualified family physicians in their first 5 years of qualifying. But yeah, it is also interesting, maybe also because in a way we are pluripotent in our training as generalists, that our skills mix is and how we apply them is also determined by the local context. So we are responsive. So it might be that in a smaller district hospital that's rural, where there's no clinical manager, often the family physician might take on the role or some of the roles of a clinical manager and complement the management team in that way. Whereas in other settings, I mean, I've heard of family physicians playing the role of consultants in larger district hospitals and level 2 hospitals as well. So, and some might migrate more into a teaching direction, more leadership, governance role. But I think the clinician identity is core. I mean, we are at our very core seen as we see ourselves as primary care practitioners working in teams. So I think that is a core identity. As to your last question, just remind me again, was that again about?
It was just a comment, and I was just in terms of explaining the community health centres versus the district hospitals, in a sense that there were more kind of, I guess, places for impact for the family physicians. So it was just one of the things that came to mind when you said, why is there this difference? And I think that from my perspective might be one of the places, but I just thought I'd love to hear what you thought about that.
No, I agree completely, and thank you for reminding me. I mean, I might also be that maybe the way how family physician posts were created and how we were deployed, and maybe also how our training was, is that is maybe more skewed to hospitalist care, and so that might be the one thing. But it's also the service needs on the other hand, because the primary care facilities are nurse-led and really, so maybe there's this established culture and services. So there's probably I'm as you can hear, I'm guessing now about, like you say, is also trying to give an informed guesstimate about what would be the possible reasons, but our at the time when we were writing up these results, trying to make sense of this different perceived or effect of family physicians in district hospitals compared to primary care facilities, our thinking was that even though we were trying to be as good with matching the facilities between the family physician containing and those without, is that probably that there are things that were unmeasured, much like Virginia has also alluded to, that there are probably confounding variables that we were not aware of at the time. But also in retrospect, with the district manager interviews, one of the chief directors at the time also made a very interesting remark about the individual in the post, how the individual is able to realize their impact, whether they are in a way able to influence the system, like you say, with change management, all those things, or whether they're at the mercy of the system. So it might also be another factor that the individual realization or manifestation of that family physician's influence is in a way impacted by the organizational culture and climate and support from the local management team for their influence. I mean, as a family physician myself, working previously, I've worked in different settings where there were also different appreciation of what my role could be, I think in the early days, it was especially challenging around highlighting the job description, just to create a clear guidance about, so what is the role of the family physicians? But luckily, I think now in the metro, in the Cape Town, we are very close to finalizing an agreed joint job description for family physicians, both joint and non-joint, which will hopefully also help orientate the other management and team colleagues about the role of the family physician, which I think will also then hopefully translate in a more shared understanding of their contribution. So it's a local conversation that we actually are busy with at the moment. But thanks, Carl, for I really appreciate your contributions.
Thank you.
Thank you.
Klaus, thank you very much. Actually, your last answer touched on the point about generalists and how us generalists have the dichotomy of having rich complementary skills, but with the double-edged sword of that also being a difficult one to fit in a world that recognizes super specialists ahead of generalists in in a general way. So basically, that's another talk for a whole another session. So we've now officially hit the 90-minute mark, so the full-fledged Hollywood feature film duration. And so I'm going to wrap things up. Thank you very much for your very, very enjoyable talk, and it was very well attended and stimulated a lot of discussion. So that really is great to see. And so we look forward to your next talk already. Thanks everybody for coming, and we hope to see you all and many more at our next talk in 2 weeks' time. So I'm going to wrap it up there. Thank you, Klaus.
Thank you, Jeroen. Thank you very much, everyone.
Bye, everybody.
Bye-bye. Thank you.